Hello fellow learners, this is Group 2, and today's discussion will be Simulation and Technology in Medical Education, a double-edged sword. There is no doubt that technology is being increasingly utilized in undergraduate, graduate, and continuing medical education. In fact, some may argue that we're encountering a shift in the pedagogical paradigm in these venues. However, technology is not a panacea. Technologies on their own will not alter the fundamental fact that learning a discipline such as medicine will always require considerable effort on the part of both students and educators. However, there is evidence that technology can enhance teaching and learning when used thoughtfully and appropriately. And for the purpose of today's discussion, when we talk of medical technology, we'll largely be referring to two major categories of technology, that of clinical simulation and that of e-learning. Now, simulation is the imitation of the operation of real-world processes or systems over time. And in medical schools and academic medical centers across the country, sim labs are being increasingly utilized to teach, practice, and assess diverse cognitive, technical, and affective skills. Now, simulation comes in many different flavors. On one end, you have low-fidelity task trainers. These are relatively inexpensive, simple trainers that can be used to teach and practice different aspects of the physical examination or to teach the performance of basic procedures. On the flip side, we have high-fidelity simulators. These are much more expensive, much more sophisticated and technologically advanced. These include human patient simulators, surgical simulators, and virtual reality simulators. Now, these simulators, very much like the low-fidelity task trainers, can be used to teach, practice, and assess basic skills, but oftentimes they're utilized to create a much more complex clinical situation where a learner needs to perform and integrate many different cognitive, technical, and effective skills in order to perform the task appropriately and have the desired outcome. And then finally, we have standardized patients. Standardized patients can also be used to teach and practice basic skills, including physical examination skills, medical interviewing skills, interprofessional skills, and can also be used for both formative and summative assessments in the form of an OSCE. Now, e-learning is a very diverse category. Most e-learning nowadays is found online, and this can vary from having posted written materials readily available for students, or can be previously recorded lectures, podcasts, vodcasts that the learner can access at his or her own convenience. One form of online learning that is now in vogue in medical education is the flipped classroom. This is much different than a traditional classroom where the majority of class time was spent with the focusing on the mastery of certain content and knowledge, and then with the assignment of homework that the learners had to do outside the class to apply that newfound knowledge. The flipped classroom does the exact opposite. With the flipped classroom, learners are expected to do their homework before they enter the class, and that homework is really focusing on knowledge acquisition. And the hope then is that the learner comes well prepared for class and now can use that newfound knowledge to apply it to solve authentic clinical problems during the defined class time, hence the term flipped. And then finally, we have simulated cases. Simulated cases are a little more advanced in the sense that a learner will go through a case in a stepwise approach. They will be provided with certain clinical material, and then oftentimes there will be formative assessments that the learner must participate in order to apply their knowledge. And as the case proceeds and as more clinical material is made available to them, the problem solving becomes much more complicated and difficult. Now, like anything else in life, medical technology has both its benefits and its shortcomings. When we talk about clinical simulation, it's obvious to see that there are several diverse benefits to incorporating clinical simulation into a curriculum. First of all, it allows medical educators to teach, practice, and assess diverse skills in a safe, controlled environment. Again, the focus can be on the acquisition and application of cognitive, technical, and behavioral skills. And because this is performed in a controlled environment, you can also promote patient safety. To think about it this way, learners are learning the development and application of skills in a readily observed area on mannequins or standardized patients, and this is going to incur very little risk to real patients. In addition, learners are now very well prepared to transfer all of these skills that they've learned to a real life clinical situation. And having practiced them, the expectation would be that they could perform this in a much more competent and safe manner. In addition, clinical simulation allows for the development of a more authentic environment that allows integration of more complex skills. In fact, when we start to talk about Miller's pyramid, simulation can be used to force learners to demonstrate that they know how to do something, or forces them to show you how they can do something. So you can hit the knows how and shows how levels on Miller's pyramid. Clinical simulation also allows for iterative practice. In other words, a learner can continue to practice a skill within this safe, controlled environment, do it multiple times until they've ensured the achievement of a minimum level of competence. In addition, this allows for immediate feedback and corrective actions. So one would hope for a very steep trajectory on the learning curve. Clinical simulation also allows medical educators to meet the individual learning needs for a diverse population of students. In fact, simulation can be tailored for individual professional development. One example may be a medical resident who does not yet feel comfortable running a code blue in the hospital environment. In that situation, a faculty member could work with that individual, put them through a series of different exercises, observe their performance, and give constructive formative feedback to ensure that their skill is improving at the desired level. Clinical simulation can also be used across the continuum of medical education. There's no doubt that simulation is being used increasingly at the medical school level in both the preclinical and clinical years. In addition, simulation is now being used in residencies and fellowships at most academic medical centers. In fact, it's now an ACGME requirement. And we're actually now seeing that simulation is now being incorporated into continuing medical education. One example of this would be ACLS certification, for example. Another huge benefit of clinical simulation is it really does help promote interprofessional education and teamwork. You can have multiple learners of multiple different specialties in the same simulation scenario, each needing to perform specific tasks and roles in order for the simulation to go well. This group performance can be readily assessed through direct observation. Formative feedback can be provided, and the performance of the group will hopefully perform over time. And then finally, clinical simulation allows educators to expose learners to critical but rather uncommon presentations. You can think of simulation, therefore, as as batting practice. It's analogous to batting practice in baseball. Um, you can prepare learners for all types of situations, and the hope would be that if they are well prepared, when they finally get into the game and are now faced with that clinical dilemma, their performance will be at a much higher level than if they've never gone through these exercises before. So those are the benefits of clinical simulation. In terms of e-learning, there are also several different benefits for both the learner and the educator. First and foremost is the ease of dissemination. Now that everyone is connected on the World Wide Web, it's easy for learners to access materials, whether they're written or recorded, at their own convenience, in their own house, on their own devices. So whether they are a mile away from the institution or 1,000 miles away from the institution, they can easily access these materials. This makes it very convenient for all stakeholders, namely the students and the educators who can post the materials on a regular basis. E-learning also allows the educators to achieve congruence between desired learning outcomes and delivered content. In other words, they can develop very specific learning objectives and then ensure that through the activity, those learning outcomes are met. E-learning also allows the efficient transmission of basic content. In medical education, it's easy to teach your basic illness scripts and prototypes through certain case exercises, for example. In addition, e-learning allows for the review of material if it's not initially mastered. So if a learner has reviewed, let's say, a recorded lecture, still is finding gaps in his or her knowledge, they can go back and review the lecture in real time and fill in the gaps. When we talk about online cases, these cases allow for stepwise progression through the case, and this can increase engagement and critical thinking. So not only are we just focusing on the acquisition of knowledge, but these cases can therefore promote the application of that knowledge to solve certain problems. This is often done by integrating formative assessment exercises to ensure such understanding of material. When we talk about the flipped classroom, there are several different benefits. First of all, having the students do their homework before class time ensures the acquisition of the basic level of understanding prior to class time. That allows the educator to allocate class time to educational strategies that can promote the application of that knowledge. So you achieve a much higher level of learning during class time. And this can therefore allow for concept clarification, solving authentic clinical problems, and group discussion in a team-based format. In addition, e-learning is relatively inexpensive after you've initially purchased whatever software or online technology is necessary. Once that's in place, it's not difficult to develop materials to post them online and for the learners to access and utilize them. So those were largely the benefits of such technology in medical education. But as we've said, not only do we have benefits, but we also have certain limitations and constraints when we utilize these technologies. With clinical simulation, probably one of the biggest limitations is that although it's more authentic than reading a textbook or having a case discussion, it's still not completely authentic. And as a result, the skills that one learns in a simulated session may not be completely transferable to real clinical practice. In addition, sometimes it's hard for learners to appreciate the importance of partaking in these exercises and for them to take it seriously. Um, some learners will often say that this is all well and good, but it's still not real life. And such an attitude may be counterproductive to what we're trying to accomplish as medical educators. In addition, with clinical simulation, there is usually a high initial cost to constructing, developing, and running a simulation center. Now, obviously, high fidelity simulators are going to be much more expensive than low fidelity simulators, um, which can be utilized outside the sim lab. But for the most part, when we talk about simulation labs, this is a rather huge investment. Clinical simulation, um, again, can be used to help teach, practice, and assess uh, diverse skills. But this is very time and resource intensive within the curriculum. And when you talk about the amount of information that medical students and residents need to learn, um, the increasing clinical requirements that they face, and the diverse responsibilities that educators have at both the academic and clinical level, it's sometimes difficult to implement a well-developed simulation activity in a curriculum that is already chock full of pedagogical exercises. Clinical simulation can also be limited by the fact that it requires trained educators and patients. Um, to run a well-developed simulated patient scenario often requires several hours of education with that simulated patient so that they know what to expect, how to respond to different questions, um, what to occur if the case goes in this direction. And so that's an additional cost in time that both educators and patients CRM's patients need to put into it. And then finally, as we'll talk about more in depth in a moment, it's difficult to develop valid and reliable assessment tools for simulation exercises. Now, e-learning also has its limitations and constraints. First and foremost, e-learning often focuses on transmission of knowledge with limited application of knowledge to solve authentic clinical problems. So recorded lectures are all well and good. They may help the learner understand the material better, but it's not going to necessarily promote the application of that knowledge. Now, simulated cases will, in fact, mitigate that somewhat and provide for a more authentic environment where learners can apply that knowledge. In addition, e-learning may oversimplify clinical problem solving. Oftentimes, the cases that are developed for this purpose, they often focus on the prototypes, but not the exemplars. So sometimes learners have a false sense of security uh, knowing that this is the textbook presentation of this particular disease process or that particular disease process, but don't develop a full appreciation of how atypical a certain disease may present. They don't understand those exemplars. Those are experiences that can only really be dealt with and that one can benefit from through real life clinical exposure. Another shortcoming of e-learning is limited interaction with the peers and the instructor. There's less team discussion, group discussion that may hamper the development of an individual's knowledge base. In addition, the learner may not be able to ask for clarification of concepts in real time. This may force that student to look up that information on their own or have to wait until they can communicate with their professor at a later date. Like all other technology, e-learning also puts both the student and the educator as a victim to technology. Such technology is great when it's working well, functioning well, but if there's a glitch in the system, if there's difficulty in playing the lecture, this can really hamper learning. So it's important to make sure that the technology is up and running in a very efficient and proficient manner. And then finally, with e-learning, it's very difficult to individualize learning. You really are focusing on uh, core topics, core discussions that you want every learner to have a firm grasp of, but it may not promote the individualized learning process, as everyone's learning needs are much different. And perhaps the biggest limitation of these technologies is in how we can ensure clinical competence. On the screen before you see Miller's Pyramid of Clinical Competence. And as we move up the pyramid, up to the pinnacle, what we see is that clinical competence here is much more authentic. So at the very bottom, for instance, we have knows. This is basic knowledge that can be readily assessed by written examination. At the next level, we have knows how. Has the knowledge and can apply it to solve basic problems. This may be be able to be observed and assessed through clinical cases, clinical problems. Then finally, we have shows how. This allows learners to really apply different cognitive, technical, and effective skills to solve more authentic clinical tasks. These are things that may be seen or assessed by OSCEs, standardized patient scenarios, clinical examinations, so on and so forth. And then finally at the top, at the pinnacle, we have does. This is that the learner actually takes all of these skills and actually utilizes them and applies them in a competent manner in the workplace when they're not being observed. Now, why is this important for our discussion? Well, if you think about it, both e-learning and clinical simulation really focus on the knows how, and at the highest level might reach the shows how, can demonstrate the performance of the skill. But when we're talking about ensuring clinical competence, only workplace assessment can you ensure that the person is actually applying it to real life clinical medicine. And so this is probably one of the biggest shortcomings of all of these pedagogical tools is in the assessment. We can get up to maybe the shows how, we can certainly hit the knows how, but we can never get to the does. And so what we can think about is that these technologies can be used to prepare the learner for that subsequent performance in the workplace. So in other words, effective e-learning and simulation can be viewed as a curriculum design issue. And these technologies are tools, but they're not the teachers and they're not the end-all be-all. They can be used for the preparation of the learner. They can be used for the basic assessment of the learner, but they cannot replace the importance of real-life clinical practice and clinical experience. So this is group 2, talking about technology and medical education, how it is in fact a double-edged sword. Thank you.